So I have no financial disclosures, and as mentioned earlier, we prefer if no photographs are taken through the presentation because the content has patient-related information. In order to make it clear for the staff, we have defined 10 critical areas as areas for patient safety. And this is the list of what each of these goals are. So the goal 1 is to ensure the patient, we do the surgery on the correct patient and the correct eye and procedure. Second is the correct implant and power and the IOL design. The third is to prevent mortality and morbidity because we are also working on vulnerable patients. Goal 4 is to prevent any hospital-acquired infection. And goal 5 is to eliminate sight-threatening complications like endophthalmitis, expulsive hemorrhage. Goal 6 is to eliminate medical or diagnostic errors. Goal 7, ensuring correct medication. Goal 8, ensuring correct spectacles. Goal 9 is ensuring physical safety, no falls in the premises. And the last goal, to ensure treatment and follow-up of these patients who are at high risk. Now, of these goals, we'll be covering the first 2 goals today. So I'll be focusing on goal 1, which is to ensure we have the correct patient treatment. So just to give you a scenario, there was a situation where a patient, just before surgery was started, we realized that at the timeout stage that the patient actually had the wrong case sheet. And how did this happen? So there were 2 patients, both with same names but different last names. And in the OT complex, they were there with the respective, one was a toric IOL, one patient was a monofocal IOL. Now, as the patient was called, the toric case sheet was taken, and when the patient's name was called, the wrong patient who was supposed to receive a monofocal lens was accompanied by the staff with a wrong case sheet. So at this point, this patient with the wrong case sheet, so the patient who was supposed to get a monofocal had a toric IOL case sheet, and surgery was about to start, but thankfully before timeout, this was identified. So this event was averted. So why does this happen? So as we all know, it's not uncommon to have the same name in numerous patients. So it's very important to not just rely on only the first name. So it's always important to have at least 2 identifiers. You talk about patient's name, but also include the last name and have one more identifier, like which area or care of the attender's name, etc. In our system, we use the electronic medical records. So while we are trying to, while we provide care at every station, right from the time when we check the vision to the investigations or doctor examination, we ensure that all of this, we verify the patient by taking the ID card from the patient and entering the last 3 numbers of the EMR number onto the EMR. Only if these 2 would match, would the EMR open. So this is how the system is set. The idea is to prevent any errors happening. And we also try to ensure the patient is always holding on and not giving the ID card to any of the staff members after the care is completed. So this is another situation when a doctor found out that the wrong eye was operated during the post-operative examination. Surgery is over. At 1 week follow-up, we realized the situation. So how did this happen? At a campsite, we had a patient who had the same vision in both eyes, and right eye was advised surgery. At the base hospital, once the patient was brought in, the same evening we had the fundus examined, a macular scar was noted, so the advice was changed to the right eye. However, the patient continued to the left eye. However, the patient continued to have the wristband in the right hand. So the advice was changed in the case sheet, but the patient's wristband was still on the wrong side. So because of that, the right eye or the wrong side was blocked, and the wrong side or the right eye was operated. So this was identified later in the follow-up period. The good news, thankfully, was that the IOL power was same in both eyes, so we went ahead with the other eye subsequently after this error happened. But this is one situation which happened. Again, very much preventable, but why does this happen and how do we prevent this in future? So after this, we realized we have to kind of modify the protocol. The doctor should document the reason in the EMR and the manual record. So one has to document clearly, why are we changing the eye from right to left? Is it really required? It has to be done so by a senior consultant, and we'll have to share this information with the entire team because it's not just information in the EMR, but to enable the right patient flow, to have it, the wristband changed, counsel, so we have the A scan, a fresh A scan with the correct eye highlighted, You inform the OT staff, the counselor also. So the whole team has to be aware of this change. And after doing this, the correct eye is marked after verifying with the wristband and the case sheet. Now, to ensure the correct eye, every step of the process is important, right from the primary examination done by the refractionist, the OP staff, the doctor, the biometric technician. Check if the correct eye is advised, if the right eye is counseled, and if the right eye is operated, and the documentation. So why each of this is mentioned is because at any point during caregiving, this mistake can happen. More so if it is being handled by different staff, and typically that's the case. That's what happens. So even if you have 2 or 3 staff, one staff does not do 100% of the work. So they may be doing multiple points, touch points. So it's important at every touch point that this verification is done. So the verification, like we speak about doing a timeout before surgery, but at every point one has to do it. Even before the procedure, even before the patient enters the block room, we check to ensure that everything has been done. Is it aligned? The wristband, the eye marking, is it correct? Is the A-scan sheet attached? Do we have the IOL power, correct eye highlighted? IOL is available, the right power design, all of that. Again, while in the block room after checking for your vitals, before giving anesthesia, at the OT substore where the IOL is received to ensure it is matching, and before escorting to OT, because even at the station when the IOL is received, we realize sometimes the case sheets can switch. Before the procedure, before you give your block, before you drape, and the surgery, and again once more before the lens implantation, because we've also had situations where sometimes the IOL might have dropped, and while trying to pick up, you might have picked up a different lens, put it in a different box, and that could also be a mistake. And finally, once the procedure is over, the documentation also has to be correct to ensure the patient has the correct appropriate post-operative care. Now, the universal protocol is something which is very important. I think this has been said multiple times in healthcare, that this is the most important step every caregiving team member has to follow to ensure we prevent wrong eye or wrong events. One is to pre-procedure verification to confirm the correct patient, procedure, and the site. Second, again, very important is site marking, especially as sir has mentioned. Considering we have the laterality issue in ophthalmology, we'll have to take a lot of care, and a timeout is a must before starting the procedure. Eye marking is typically done as soon as you receive the patient and you confirmed with the patient and you have the wristband and all that is done. It is done by one person in the medical team after verifying with the patient and checking with the case sheet that it is the right eye. And we also have attender before this is done, especially in children, but even adults as well. It's always good to have the attender along with them, because most of them are vulnerable patients, so it's good to do the eye marking in front of another person. The surgical safety checklist was popularized. I think we took this cue from the airlines industry, and now it's a mandate. So all of us have to have a surgical safety checklist at 3 stages. That is before anesthesia, which is the sign-in, where you verify the patient's MR number, is the correct patient, the eye to be operated, have they taken their pre-op medications, any allergies, if so, has it been documented, are we avoiding those medications, do we have the wristband in the correct hand. So we have tweaked it a little bit for ophthalmology, but based on the system, you can always do a little change here and there. Check the type of surgery and IOL. Is pre-op iodine important, because that has the highest evidence to prevent endophthalmitis. Again, time out before incision, we verify all of this with every member of the team, which is the surgeon, the assisting staff, and the circulating staff, and the sign out. So you verbally confirm the procedure has been done. Is it the right procedure? Any deviation, any post-op instructions. And each of these stages, it has to be signed, timed, and dated as well. So what is the cause of wrong site procedure? Like I said, if most of the errors happen because the universal protocol has not been adhered to. That is, we have not checked before doing the surgery on the correct site. We also have something called as upstream errors or downstream errors. Upstream is something which happens before you've administered the universal protocol. Example, will advise itself, if the doctor has advised the wrong eye surgery, there is no way, even if you adhere to the checklist, you will be able to identify it. This is one site. The second thing is downstream errors, where you can have a problem after the universal protocol has been administered. Like in case the IOL is being changed for some reason, the patient has a rent and a new IOL is brought. At that point, you haven't rechecked. That can be a reason why you have a downstream error. But most of the time, This could be preventable if we follow the universal protocol. Now, there are situations when you have what we call as a near miss. Now, this patient had a cataract in both eyes. The patient had a mature cataract in the right eye, but the doctor end of the day, we have to realize errors will happen. We are all human, and to err is human, as we know. So, of course, we'll have to be very, very conscious. But are we also having the team vigilant enough to pick it up right when it is critical? So at this phase, the right eye was the mature cataract, but left eye was advised. But the counselor identified and brought it to the notice of the physician, which made it easy for us to change. Now, any of such events also has to be reported. So we have an internal incident reporting process. It's an online platform through the intranet where every of these incidents and these near misses are reported, not to point a finger, but just to bring in a culture of safety, to bring in a culture of responsibility. This is elevated. We also use this information in our training systems and also to influence behavior. So this is an event which Arya sir just showed where the correct process was followed until the very end. In spite of it, the other eye was blocked. And this was something which can also happen. Again, because right eye, left eye, where are we giving the block? So the doctor, you may have the marking, but the cap may be covering it, or the wristband may be in the wrong hand. But here, even if it is all right, you're able to see the mark, correct wristband. Sometimes if you're not aware of what you're doing, we've also had instances when you can have an acute failure. So the corrective action now is that, of course, you'll have to adhere to the universal protocol and double verify. So we have one more staff also besides the doctor who's giving the blocks to ensure that we avoid this wrong eye block. So this situation is when the one patient was advised refractive surgery, transepithelial PRK, and this was most of the work in the system is done by the refraction paramedic, and this was reviewed by the doctor on a manual sheet. Now, while the procedure was being done, this was not cross-verified. So instead of the transepithelial procedure, the wavefront procedure was done. And what this happened, and this basically we had to go back and redo the right procedure a couple of weeks later. But what happened was the right method was not followed. So no verification method for the software workup entry was done. And the assisting staff also was not actually well trained or well aware of the difference in these procedures. So like I said, we went back and did the procedure. We introduced a new refractive surgery checklist after this incident, and we also ensured that our team was much better trained. So what I'm trying to say is you may need to relook, so any incident you have, any sentinel event you have, you should have an immediate you have to have a meeting, bring the stakeholders together. Again, not so much to point a finger, but see if you can make system changes, like introduce a checklist, talk to your team, and enable better training processes, to influence behavior. For all of this, you'll have to ensure you have that review meeting. This other case where this patient had chronic diabetic macular edema was advised intravitreal injection. Had come about multiple injections earlier, and this patient was advised intravitreal tricot, and patients paid for the procedure. And when the patient was about to leave, the doctor said, since the IOP is high, we'll just have a glaucoma clearance before surgery. And the glaucoma consultant deferred IVTA and said, we'll go in for anti-VEGF. However, this advice was changed in the EMR. But what happened, the counselor did not mark it clearly on the case sheet. So what happened? In spite of the clinician seeing the patient, IOP being measured, advice being changed, in spite of all this being done, all of this went for a waste. The patient again went in and received a IVTA. So I'm just saying, but these are very rare incidents, so we don't take them seriously, but all of this is situations which can help us learn for the future. So the last, towards the end, just to see an Aravind eye care system, we have had about 11 wrong procedures, wrong site. This is all inclusive, wrong injections, wrong laser, wrong site. This is out of 728,000 procedures done amongst our 14 surgical centers. And we have had 8 situations where we had a near miss, that is the wrong eye was blocked. And these are the reasons why. Of the 11 situations, 3 were acute failure, and in 8 cases, there was system failure. So which means that if you can ensure that everything happens properly, right, so the entire team has to be aware. So if the MRD staff, for example, puts the wristband in the wrong hand, there's a high chance things may go wrong. So we'll have to be vigilant, and every near miss has to be, in case you find the wristband is in the wrong hand, before surgery. That is also reported, so that team gets a little more conscious the next time. So here the different causes were the manual documentation in the OT list was not done properly. So instead of SOR was mentioned instead of SOR with phaco. Missed A scan, so the patient could not receive an IOL on table. The wrong eye was prepared, so while the drape was put on the wrong eye, so that was one reason. The patient identification error, because the case sheet was exchanged in one patient. There was a change in advice after the other clinic opinion, because there could have been a glaucoma or retina, the eye was changed, but the follow-up was not there, so this resulted in an error as well. And a wrong eye surgery because change in advice in the base hospital for a CAMP patient. So when they are in the CAMP site and they come back to the base hospital, again we may change the eye for different reasons as was just showed, and that could also be a reason. So what went wrong? So we just looked at the different reasons. So sentinel events, the next step, just these are the questions we'll have to answer for ourselves. How did the error occur? By whom and when was the error recognized? Who was the responsible person? Was the patient informed? That's a totally different information as to how you will handle such patients. What was done to the patients? Or what was the corrective action? There are two aspects. You have to do a root cause analysis and a corrective and preventive action. Corrective is that patient getting the right care, and preventive, what will you do in future to avoid such a situation? What was the outcome? Was the incident reported? Within 24 hours is mandatory. What are the policy changes? Was the patient refunded if required? And what have you made alterations in your system to prevent it? And there are barriers sometimes. Sometimes we don't want to take it that it won't happen to me. I must be, all of this can happen. So you'll have to go. It can happen to anyone in the system, including, the senior most person in the organization. And also the junior most staff should have that confidence that it's okay to speak up. If someone senior is doing something wrong eye or whatever, they should open up and say, sir, I think we'll just check the case sheet once more before you start. That's something we should also enable or empower them with. So the way to go forward is to strengthen the training, conduct regular meetings with your team, and to strengthen the incident reporting. So to conclude, the goal is to be 100% correct and not 99.9%. That is still not good enough. So you still may have an error, but you always want to be 100% correct. And for that, a comprehensive timeout and deployment of checklists by more than one person would be critical. Thank you.